This is an interview with David Pratt on July 11th, 2008, at the Centers for Disease Control and Prevention in Atlanta, Georgia, about his role in the Smallpox Eradication Project. The interviewer is Alyssa Koski. With this interview, we're hoping to capture for future generations the memories of participants and their families involved in eradicating smallpox. This is an incredibly important and historic achievement, and we want to hear about your experience. I have some questions to guide you, but please feel free to recount any special stories or anecdotes that you remember about events or people. The legal agreement you signed says that you are donating the oral history to the U.S. federal government, and it will be in the public domain. For the record, could you please state your full name and that you know you're being recorded?
Sure. My name is David Pratt, and I am aware of the fact that I am being recorded.
Thank you so much. Thank you for being here today and for being willing to share your experiences. I'm going to start with a question about your childhood and how you grew up. Could you briefly describe for me your childhood and your pre-college education and how you became interested in public health?
Sure. I grew up in a small town in Massachusetts, Newburyport, Massachusetts, and did my primary grades in Newburyport, and had nobody really, well, I should say not nobody, I had two aunts who were nurses, and I think they perhaps had influences. Nobody in my direct family, though. Neither my parents nor my grandparents were involved in healthcare in any way, so perhaps it was my aunt's influence that got me interested.
Okay. So how did you become involved with CDC, and particularly the Smallpox Eradication Program?
It's a very interesting question. I went to medical school at Tufts in Boston, and while I was a medical student at Tufts, there were people in infectious disease who were fellows in training in infectious disease, and one, Kenny Ratson, had actually been an EIS officer. And I was a medical student while Ken was a fellow, and in discussions back and forth about a variety of questions and interesting topics, he shared with me and with the other medical students what it was like to be an EIS officer. So I became really quite interested in that. At the same time, at Tufts Medical School, Jack Geiger and Count Gibson were running a family medicine program. And they were doing some very interesting things with social medicine in Bolivar County, Mississippi, and in housing projects in South Boston. So the complete picture of what public health could be like, from the social-economic and cultural aspects to the infectious disease aspects, really increasingly got me interested. And so I, following my medical school experience with Ken Ratson in community medicine, I applied to become an EIS officer. Now, at that time, we have to remember that the Vietnam conflict was ongoing, and choosing a career in public health was also ethically more comfortable for me at that point in my life. So it was a wonderful way to serve the country. It was an exciting area to learn and be a health professional. And it was an exciting time.
Okay. Thank you. How did you specifically end up in India? You mentioned a little bit prior to this interview, as we were being introduced, that you actually had an option.
Right. When EIS officers in my cohort came to CDC, we had a choice of what kind of assignment to take. There were assignments here in Atlanta, and there were assignments in the field with state health departments. And I chose to actually take an assignment with the Hawaii Department of Public Health. That group was doing routine state-based public health, but in addition that we were doing some vaccine development, specifically an intranasal vaccine with measles. It was clear for the group of people who came in when I came in to the EIS that there were going to be opportunities, international opportunities. One was an opportunity in Nigeria. The Biafran famine was ongoing, and huge amounts of migration of Nigerians, ethnically diverse, moving across the country, and a great deal of hardship and despair with that. And EIS officers were given an opportunity to go and actually do assessments, surveillance, measurement around the famine. The alternative option was smallpox eradication. When we came to CDC, the West Africa campaign was largely victorious, and a very clear strategy had been laid out by Henderson and others, and so those two options were available. And ultimately, I chose to turn down an offer to go to Nigeria and accept the offer to go to India in 1974.
Okay, what influenced that decision? Why would you have rather been in India?
I think two things, really. One was I think even then I understood the magnitude of what we were going to try to do. I also thought that the work in Biafra, though important, and doing the assessment of the famine and the impact of famine on the health of those children was important. I thought it was also desperately sad, probably tougher going, and I thought that the chance to have an opportunity to play a role in the eradication of a disease was very significant and exciting, and India also interested me a great deal. As a resident at the University of Michigan, I had a medical student who talked in very interesting terms about work that he'd done in India. And so I was intrigued by his descriptions, I was intrigued by the challenge and the opportunity, and decided that when the call came from Lyle Conrad here at CDC, that it was a good thing to do.
Okay. Can you tell me a little bit about your role when you arrived in India?
Right. Well, I think to step back just a bit, it took a fair bit of convincing in my own life circumstance. I had just had an infant son born way away from family, so my wife, and this was our first child, so she was there to take care of a child by herself when I trotted off to India. And we knew communications was very poor. Telephonic communication was virtually non-existent in the areas that we were going to be in, and telegrams were iffy. So I had to really convince my wife that this was of significance, great enough significance to allow me to leave her and my son to go and do this. So the context was socially challenging for me personally, but I thought very important. So the routing that I took was basically from Hawaii over through Thailand, from Thailand up to Delhi, and then when we got to Delhi, we were met by the WHO people at the regional office in Delhi and began a briefing. And I think it's important to explain or share how dramatic the arrival in India was for us in 1974. The gulf in terms of economics and in terms of the way the place looked from where we had come from, that is Hawaii and mainland United States, was incredibly different. The smells, the sounds, the beggars at every stoplight, just the crush and the throng of millions of people, it felt like, was very different. And for a while, the truth is that I think we were stunned, literally stunned, and it took us a while to kind of catch up with the fact that we were in a brand new environment, very different than the West. And so there were going to be lessons to be learned about the economics, about the sociology, about the psychology of this new terrain that we were entering. So those first few days were very challenging I think for all of us.
Of course, there was the challenge with your wife and son. Did you encounter any other challenges when you first arrived? Housing, food and water, anything that you can recall like that?
The WHO team in New Delhi arranged to pick us up at the airport, which is always interesting, and it hasn't changed too much in India, getting through the airports. And they brought us to our hotels. They had things pretty well arranged, the logistics pretty well arranged for us. The hotels were certainly comfortable, not lavish, wasn't anything we expected. And I think they built a very nice routine, a briefing routine for us in Delhi before we went to the field. The food, of course, was very different than what I was used to in Hawaii, but I always have been sort of an omnivore and interested in different cuisine, exotic cuisine. So that was fine with me. I was good with that. I think where it got interesting is when we went by train across the north of India a group of us all together to go to our duty station, which was in Bihar. Now, at the time, I really didn't realize that Bihar was among the poorest states of India, and that the poverty that we had witnessed in Delhi was going to be compounded by the kind of misery that we would see when we got to the Bihari regions across the Ganges River to the north. So it got more interesting rather than less interesting as we went further and further to our duty stations.
Okay. Can you describe to me a little bit about what happened when you arrived in your duty stations? What was your role? How did you interact with your team?
I was assigned to two areas, two states or two regions inside Bihar. One was called Saran, S-A-R-N, and the other was Siwan, S-I-W-A-N. The stepping off point for those assignments was in Patna, and you may remember from Lord Jim, the name of the boat in Lord Jim is the Patna. Ill-fated boat. Anyway, we went to a hotel, Patna, where we had a further briefing on Bihar and our duty station, and then, very interestingly, took ferries across the Ganges River. And there were some wonderful lessons about the ferries. It turned out that moving a WHO Jeep across the Ganges River was not as easy as simply pulling up and buying a ticket. It turned out that if you pulled up and bought a ticket, everybody went around you. And the reason everybody went around you is because there was another payment being made that was invisible beyond the ticket, so-called bakshish. So if you didn't understand that if you really wanted to get that ride across the river, it would be the ticket plus some bakshish, you would wait a long time at the ferry head, the ferry dock. So crossed the river by ferry and then got to Chopra, which was the area that was my headquarters for those months that I served in that region.
Okay. And can you tell me about the smallpox situation when you arrived?
Right. There were lots of outbreaks going on. I think at the time that in my region there were 18 or 20 outbreaks that were in the midst of being dealt with, controlled, contained. A wonderful experience for me as I reflect on it was the first day in my region we went by Jeep to an outbreak. And at a village, we went into a mud hut in the village, and a woman presented me with her infant covered with smallpox lesions. And I picked the child up as you would to examine anyone. The child was pretty miserable and had still persistent fever in spite of a fairly well-developed rash. And the thing that really struck me was at that moment, I was betting that my immunization was sufficient to keep me healthy as I went forward in the program. And so it really was a challenge, how deeply do you believe in immunization? How profoundly, how profound is your faith? And so it was obviously pretty profound. I examined the child and on we went. I mean, I'm recognizing that the case fatality rates, are 25%. So, I mean, it's a huge gamble, really, that things are going to work. I mean, we all knew the history of the immunization, that it was robust and successful. But when it's you, with a child at home and so forth, and you're beginning an assignment, you'd rather not get a dreadful illness in the middle of India.
Of course. So can you describe to me a little bit about the progression of your assignment there, from your first day onward? How did things move forward?
Moved from that day, seeing that outbreak that very first day, it was right at the tail end of the monsoon. Humidity was very high. Daytime temperatures were routinely 40 degrees Celsius, 104, 105 degrees. And taking notes, which I tend to be a compulsive note taker, was very challenging because perspiration would run down your arm onto a pencil, right onto your notepad or onto your notebook. So I had to find clever ways to do note taking that wouldn't saturate, my books and so on and so forth. So it was very, very warm, very dusty. When the monsoon ended, the dust began, but it was still raining during the time that we first arrived. The Indian public health people said that trying to search through the monsoon was nuts, and yet the people we relieved had done it, and had done it successfully. So we had, in some ways, bucked the standard wisdom about it, and had gotten off on a really good foot. So I was turned over a region that was well done, well maintained. I stayed in a place that was called the Circuit House. The Circuit House, they were also called DAK, D-A-K, bungalows. They were locations where the British mail people went when they delivered the mail around the country. It was basically a squat toilet. It was a shower that was heated by a tank on the ceiling, a little desk, no screens on the doors. We had bed nets that we used, and I had monkeys as my neighbors who would come in on my porch and actually come in my room if I wasn't very careful. So I had good neighbors, and the accommodations were decent. In the day it got very hot, but at night it cooled successfully. And I didn't realize, but my colleagues, my Indian colleagues, assured me that the mosquito net served a dual purpose. Not only would it keep the malaria mosquitoes from biting me at night, but it was also good as a preventive measure against cobras and kraits and Russell's vipers, which were snakes that potentially could bite you in the night because you were warm. You know, they would sense your warmth and come up in your bed. So I had no problem with that. But my Indian colleagues frequently slept on the cement floor in our building, covered with their dhotis, and mosquitoes would bite right through the cotton. It was extraordinary to see the situation that they were in at night. So that was the living situation was in the Circuit House or Dak Bungalow. And in the morning, I had a chowkidar, the servant of the bungalow. He would bring tea to me, and from a tea stall down the road. And one morning, I had my tea delivered by this little man, and my Indian epidemiologist counterpart saw this occur and was horrified, because it turned out that the man who delivered the tea to me was an untouchable. And that's unacceptable. They're unclean, so to bring me food was sort of verboten. And I, being outside the caste system, there was no issue for me, but there was like a little confab, and they discussed it and explained that really, you shouldn't do that. I continued to have tea from the chowkidar each day after that. I just, just wasn't an issue with me. But it was my first banging into the whole issue of caste was right there in the Circuit House that day.
Okay. Now, how close were your field assignments to the Circuit House? Were you working right in the surrounding villages, or did you have to travel a bit?
Oh, no, there was a fair amount of travel. We had jeeps and drivers, and, on an average day, we would probably work 8 or 10 hours driving, and you'd go outbreak to outbreak, district health officer, you'd visit with the district magistrate, you'd meet with the various people who were critical to you being able to get the project done. So there was a great deal of travel around. We all had drivers, and I have to say that the Indian, Dr. Chakravarti, who was my counterpart in Chopra, was an extraordinary guy, very bright, and could accomplish things that clearly I could not accomplish. He spoke the language. He knew how to influence in very effective ways. So he was critical. I would begin the morning by going to his home, and his wife would serve me another cup of tea. We'd lay out the day, and then we'd just simply start going. And routinely, we'd leave his house probably at 10 o'clock and not return at 8 or 9 o'clock at night that evening. And he never stop for lunch. I don't know what the guy ate, but he never stopped for lunch, so we just kept going. Sometimes we'd stop, actually, on the road, and our driver would buy in the market cow dung. These dried patties of cow dung, light them on fire, and then buy cucumbers and cook cucumbers in their skin, and we would eat those as kind of a snack, a break on the road with tea. So extraordinary things that, and cow dung was routinely used as fuel. In the morning in the villages, you could smell the cow dung burning as people began to make tea and food for breakfast.
Very, very interesting. Now, how were you received when you arrived in these villages?
Interesting. I'm 5 feet 6 years old, and they would say the big sob. The big sob is here, which I always thought was hysterical. Or they would say the American sob is here in the village. So it was a respectful term. The fact that an American would come that far to Bihar to work on this issue was felt to be extraordinary by the Indians. So in many ways, There was a great deal of respect. It was beneficial as well that I was outside the caste system because I was allowed to make mistakes and gaffes that an Indian couldn't make. And I could perhaps ask for things that an Indian couldn't ask for and get away with it. So I was well received, respectfully received, and I tried to work, carefully with the people, the Indian health professionals that were with us. It was intriguing when we were there, when we were in India. My group was in India. Daniel Patrick Moynihan was the ambassador to India, and he indirectly told the EIS, the American EIS officers who were deployed in the field, never to speak to the press. Only allow the Indians to speak to the press, and don't make any derogatory comments at all. So we were well schooled and well prepped about what not to do, what not to say in country. So we really counted on our Indian colleagues and counterparts to do a great deal of the PR and the outreach and the commentary that Ambassador Moynihan really prohibited us from doing.
Now, you mentioned earlier that you were perhaps more socially free to have some indiscretions or make some mistakes that Indian people would not have been allowed. Can you describe any particular instances where you ran into a problem or those mistakes weren't accepted?
Yeah, there were times when people would flatly refuse you because you didn't quite look right. And I remember specifically in one outbreak, a woman became very upset when I personally asked, to be able to immunize her. And I think I was bucking probably the male-female divide, Eastern-Western divide. So that was an instance where it was very clear that I was not welcome in that circumstance. But that was a minority. That was the minority. The thing that was interesting, another key learning for me in the villages, is the villages were frequently broken up into tolas or sections. There was often a Hindu section, there would be a Muslim section, and then there would be a section for tribals. And it was always humorous to me that when you spoke to the different leaders of the different tolas, they would make derogatory comments about their counterparts. And it frequently went something like this: oh, you'll never get them to be immunized, they don't know anything, they're sort of ignorant. And it was intriguing how each of them made similar commentary to the others, but at the end of the day, they all allowed us to immunize them. And the strategy was, frankly, to invite the village headman to be the first recipient of vaccine when we were doing containment. And so if the opinion leader in the village would allow you to immunize him, then all things seemed to flow, from that. So if he got it done, well, everybody would line up behind him and, would be able to do a good job.
Of course. Now, I'd like to talk a little bit about how your entire experience in India really influenced your life and impacted your career in public health subsequently.
Yeah, I mean, you have to realize that this was sort of like winning the Grand Slam in tennis at 29 years of age. Where do you go from here? It was an extraordinary event. And as the years went on and, the true eradication was proclaimed and so on and so forth, it became even more spectacular in my career. And so what do? What is your follow-on act? It's like a first novel. If it's a success, you sort of, it's a huge challenge. I think that I took a lot of important lessons from the Smallpox Eradication Program. The first one is that sometimes naivete is a wonderful asset. We really didn't know how extraordinary what we were going to do was, and we went at it anyway, assuming that, it could be done. So I think that was important, the naivete. And the other thing that goes with it is a comment that Colin Powell makes, and he says that General Powell's comment is that optimism is the most important force multiplier. And I tried to remain, the optimism that I brought to the table, I thought was powerful in allowing us to get my region, and by the way, by the time I left my region, we were smallpox free. All the outbreaks have been contained, and I left an absolute pristine area. I should say the Indians and I, as their assistant, left a pristine area. And I was always outwardly very optimistic, although as I read my diaries, I read that there were times when I was very pessimistic that we would get the job done. But ultimately, when I spoke to our searchers and spoke to students and spoke to people in the villages, I always kept that very optimistic view. That's one. I think a second big one is the fact that it is sometimes really simple stuff that makes a huge difference. For instance, the logistics, knowing where to get gasoline, knowing how to keep your Jeep serviced so that when you had to go to an outbreak, you could keep going, having sufficient rupees to pay the people who searched. Just really nuts and bolts of good management were critical to succeeding in India, and in the rest of my career have been critical elements as well. Simplicity, too. I think part of our success in the Smallpox Eradication Program had to do with the fact that we were using proven technology for the vaccine. We were using a strategy and the tactics to deploy that strategy that had been proven in West Africa. And basically what we did is execute, execute, execute. Just this kind of diligence of doing it every day, following the book, compulsively filling in all the things that we needed to, got the job done. Atul Gawande, who was a writer, American health writer, talks about the power of diligence in improving quality and care. Boy, it was sure true with smallpox. Diligence really paid off. And which reminds me of a point where things were not looking so good in early October. In fact, it was October 5th, 1974. I know from my diaries. We went to meet with Bill Foege, Dr. Foege, in Patna, and we were explaining how it was going, and the answer was not so great. And we were really working hard. I mean, we're 10 and 12-hour days, lots of driving around, and very bumpy roads. The infrastructure in India was tricky. And we met with Bill, and he said, not good enough. You're going to have to do more. And so we were saying, Jason Weisfeld and I were working in the region together, and we say, whew, okay, we can do it, Bill, but we're not sure how much more. So we went back and tried to think, how do we do this in a fashion that is more efficient, more effective, as well as putting in more hours. So that was extraordinary. So I think those are the real key takeaways: simple things, logistics, good management, proven technology, and diligence. Just doing it, recording it, measuring the heck out of it, and continuing to execute every day.
How about in your personal life? I mean, you mentioned that prior to going, you were quite torn with leaving your wife and son at such a critical time. And I mean, those obviously had to play into some of your future decisions as well. How did this experience in India indicate your personal decision to continue on in public health?
Yeah, it's great. It's a great question. Actually, I didn't continue in public health until much later. Well, I'll explain. I was invited to move from India to Bangladesh, and then ultimately it would be a movement from Bangladesh to East Africa, where the smallpox was finally eradicated. Jason Weisfeld and so forth, his team. And it was pretty clear that I was not going to be able to continue with the effort. Several reasons. I had an infant son at home. I had a commitment to continue my training in internal medicine. My father had had a heart attack. My mother-in-law died while I was deployed in India. I mean, it was a social catastrophe. So it really probably took me, 24 months before everything was kind of right in the world, in my little world back home, after I got back. So I made a conscious decision at that point to do something that was going to be less travel and more like traditional clinical medicine. I continued to drift toward public health in spite of that, and ultimately did a number of activities in clinical care that drew upon the public health model to allow me to get the good vibrations back again about public health. And then ultimately, when I retired from being a medical director with a large Fortune 500 company, now have gone back to actually go back full-time into public health, which is a wonderful place to be.
Excellent. Now, in conclusion, I'd just like to offer you the opportunity to share anything that we perhaps didn't cover, that I didn't touch on, anything very poignant about your time in India, people, places that you'd like to add.
Yeah, I mean, a couple of things. Number one is that I was a grunt in a huge campaign. And, it was my wonderful opportunity to be at the right place at the right time with wonderful leadership, Indian, international, American. It was a tremendous experience for me to work with D.A. Henderson and with Bill Fagey, Mike Lane, and a variety of Nicole Grasset, and a gentleman named Yalapurka, who was an Indian expert, a smallpox expert. So it was a privilege, first of all, to do that work. I played a minor role in a great pageant of strategy and tactics and so forth, so I'm grateful for that. Another thing is that it's very clear that it was the Indians who did the job in India. We frequently, I think, take perhaps more credit, the EIS types, but at the end of the day, the day-by-day, grind them out, hard work was done by Indians, and we need to salute them for the extraordinary job that they did. Bright people, very hardworking, deeply committed, and it was an honor to work beside them and with them. I think that the public health model that I learned, in the Smallpox Eradication Program of assessing a situation, trying to decide how do you do the greatest good with the smallest number of resources in the shortest period of time, served me again and again and again, whether it was organizing programs for farmers in upstate New York, or whether it was thinking about field engineers deployed by General Electric in Nigeria. The same thinking that I learned and was underscored in the India smallpox campaign served me again and again. So it was a wonderful learning experience for a young man. It laid a foundation, an infrastructure for a career that's been very rewarding, and I look back on it fondly as both formative and instructive for the rest of my life.
Excellent. Thank you so much for being willing to share your experience with us and for speaking with me today. Wish you the best in your future endeavors and as you continue on with your medical training.
Thank you. It was my pleasure.
Thanks.